আপনার স্ক্রিন শেয়ারটা এখন একটু অফ করে রাখেন স্যার। হ্যাঁ, আমরা ফেসবুক লাইভে আছি। ডক্টর নওশিন, প্লিজ।
Thank you. Assalamu alaikum, everyone. Dear audience, on the first week of the year, a very happy new year to you all from me, Dr. Noshin Tabassum. And it is my privilege to welcome you all to today's live webinar on approach to acute kidney injury. We are very lucky to have among us as the chairperson, Professor Ziauddin Ahmed sir, who is MD, FASH, and Professor of Medicine of Division of Nephrology from Lewis Katz School of Medicine, Temple University, Philadelphia, and Professor Emeritus, Drexel University College of Medicine, Philadelphia. And you are very lucky that you would hear from today's speaker, Professor Brigadier General Retired Mamun Mustafi sir, who is the head of nephrology from Ganashastha Medical College and Ganashastha Kendra, Director and Senior Consultant, Bangladesh Specialized Hospital. AKI, or acute kidney injury, is a very common problem that we encounter in the words daily. There is not any word that does not see a patient of AKI. Most commonly, when we find a patient, we see that their creatinine is raised more than 1.2 milligram per deciliters, and we keep on thinking, is it AKI or is it CKD? So sometimes we term it as renal dysfunction under evaluation. Now today we will learn from Sir and hear their important words on AKI. At first, I would like to take permission from our chairperson and ask him to start the session. Thank you, sir.
Thank you, Noshin. It's a privilege and pleasure to be here because of Mamun Mustafi. When he invited me, I thought it's an opportunity to learn what's happening in Bangladesh, and he's one of the leader. And also BD physicians, they're doing an excellent job for many years for continuing their CME. I remember during COVID, they did one of the program with us. So I will, instead of wasting time, I just want to hear this lecture. But one thing you mentioned already, that kidney injury is very hard to detect. If people has a heart disease, you can have a chest pain, a stroke, lung disease, liver disease, but the kidney injury, you have to look for it. So that's why it's an important topic. You have to think about risk factors, think about what's happening, and actively you have to search. Otherwise, the AKI can be a chronic kidney disease. AKI means what? Acute means reversible. So it's an opportunity to reverse the dysfunction if you can diagnose early. So I just want Dr. Mamun Mustafi to start his topics. Thank you very much.
Bismillahirrahmanirrahim. All the participants, my elder brother, Professor Ziauddin Ahmed, and all the dignitaries and the hosts of the BD physicians, very assalamu alaikum and good evening. I'm very happy that I could join you through the BD physicians to provide some discussion on acute kidney injury, how we should deal it. In fact, when the topics has been proposed, AKI is a very, very vast subject, and it takes quite a few classes to, in fact, to up-to-date this chapter. So I thought we should, as a general physicians or internist, or the persons who look after the society, what should be done by general physicians or practitioners or internists. So today I'll not go in details of the of AKI, the pathophysiology, the causology, but as a general practitioner, what someone should do, that should be our today's motto. So in any situation, we diagnose AKI with these criteria. Whether any person who is having normal renal function is found to have creatinine just raised more than 0.3 milligram or 26 micromole per liter in over 48 hours. That suffice that the patient is having some acute problem in the kidney. Or if the previous creatinine is known and the creatinine has risen more than 1.5 times, just his creatinine was 1 and now it is more than 1.5.
স্যার
That
আপনার
is,
স্লাইড স্যার আপনার
Sir.
স্লাইডটা যদি স্যার একটু শেয়ার করতেন স্যার, এবং আপনি এখনো স্যার ফার্স্ট স্লাইডে আছেন স্যার, একটু ফুল স্ক্রিন দিয়ে যদি স্যার আপনি
না না ফুল স্ক্রিনে আসি এবং শেয়ারে আসি।
স্যার শেয়ার হয়েছে কিন্তু বিসমিল্লাহির রহমানির রহিম স্লাইডটা দেখা যাচ্ছে স্যার।
হ্যাঁ কিন্তু আমি তো এই যে সেকেন্ড স্লাইড গেল।
না স্যার, আপনি স্যার কষ্ট
না,
করে
স্যার।
স্যার আরেকবার স্লাইডটা শেয়ার করেন স্যার, মানে আমরা কেউই পাচ্ছি না স্যার, সবাই বলতেছে স্যার।
স্যার শেয়ার করার সময় হচ্ছে আপনি পুরো স্ক্রিনটা মানে হোল স্ক্রিনটা হচ্ছে সিলেক্ট করে তারপরে শেয়ার করলে আমরা দেখতে পাবো।
এখন কি আবার আসছে?
জি স্যার, আবার আসছে স্যার।
এখন আমি আবার ফুল স্ক্রিন করলাম, ফুল স্ক্রিন হলো।
না স্যার, আমরা কিন্তু পাচ্ছি না স্যার।
কিন্তু আমার এখানে ফুল স্ক্রিন হয়েছে।
স্যার
না স্ক্রিন
আপনার
হয়েছে কিন্তু তোমার স্লাইড মুভ করছে না। You go to the next slide.
স্যার আপনি যখন স্ক্রিনটা শেয়ার করেছেন আপনি শুধুমাত্র কারেন্ট যে স্লাইডটা আছে ওটা সিলেক্ট করে শেয়ার করেছেন। আপনি এন্টায়ার স্ক্রিন সিলেক্ট করলে এই সমস্যাটা ঠিক হয়ে যাবে।
পারফেক্ট স্যার।
Okay, sir, we can proceed.
So in fact, today we'll discuss only the, we'll not go in details of the acute kidney injury, but whenever somebody is encountered with an abnormal creatinine of acute onset, what we should do that we'll discuss today. So as I was discussing, we'll diagnose the patient of AKI whenever there is a mere rise of 0.3 milligram from the previous value or 26 micromole from the previous value in 48 hours. Or if we know the creatinine value, if it is more than 1.5 times of the previous value over last 7 days, if it was 1 and now it is 1.6, then it suffice for the diagnosis of AKI. But many times the creatinine value is not available, especially in the villages. So in those situations, over a period of 6 hours, if the patient is not passing urine 0.5 ml per kg per hour, that would also sufficient to diagnose the patient as AKI. Here we should know, but we definitely know that the normal urine output in any person is 0.5 to 1.5 ml per kg per hour. So that means a person of 60 kg should pass at on average 660 ml per hour. That means in 12 hours, he should have 720 ml per 12 hours. I mean 60 ml per hour. So if his urine output falls 0.5 ml per kg, that is less than 300, almost less than 300 ml per 12 hours or 30 ml per hour, then the patient is having less urine output. Whenever we diagnose the case of AKI, we can stage these patients in according to these acute kidney injury network classifications. I'll not go in details today because I will not discuss AKI today. But there are stages. So if it is more than 150, then times 150 to 200 times, it is 1 to double, then it is stage 1. If it is 200 to 300, that is twice or thrice, then it is stage 2. And it is more than 300, more than 3 times of the baseline, or any acute rise more than 4 milligram, it is stage 3. So as I was discussing the urine output per hour, so a 60 kg man should pass 60 ml per hour in 12 hours. 12 into 16, that is 720 ml in 12 hours. So if it is 50%, then at least 300 ml he should pass in 12 hours. 1 glass of urine contains 250 ml. So any person of 60 kg or more passes a urine less than 1 glass a day or 12 hours. That is more enough to declare this patient is having oliguria or less urine output. So is likely to have this patient is going to have AKI. These are the risk factors to develop AKI, which can be modifiable, which can be non-modifiable. So if the patient is already with all these things, a chronic kidney disease, chronic liver disease, or congestive failure, or a patient of diabetes mellitus, an elderly patient, peripheral artery disease, the patient who already has some kidney surgery, there may be renal artery stenosis, or any of these conditions which we cannot modify, this patient is likely to develop AKI in any adverse situations. These are the modifiable situations that we can correct anemia patients. We can correct the dyslipidemia. We correct the electrolyte imbalance. So if there is chance of AKI. If there is no, it's first class. At the outset, a patient reported us with a patient of raised serum creatinine. Obviously, we have to think, we have to find out, we have to declare this patient is having chronic or acute. So all of us know how we should diagnose a case of CKD or AKI. So if we have got any previous value of raised creatinine, obviously there is no problem to diagnose. And if there is any history of predisposing factors like hypertension, diabetes, already ischemic heart disease, or any connective disease, or a polycystic disease, or any obstructive history, he or she can have a chronic disease at the outset, and the report is like is that of the previous value. But these are the clinical things that we should consider, like this leukonychia, which is not mentioned in many of the books. Leukonychia is a chronic situation. So whenever we find a patient with leukonychia, is likely this patient is having renal problem from the outset. That is chronic kidney disease. But body color is a pale, dirty, muddy color. There are itching marks in the skin. That also indicate that this patient is have CKD. CKD patients usually do not come with oliguria or less urine output. They usually come with polyuria, nocturia. So whenever a patient with chronic with raised creatinine comes with normal volume of urine, is likely that patient is not having AKI. And obviously in investigations, if there is monocytic anemia and a small kidney, we can diagnose it as chronic kidney disease. But one important thing is that this is AKI or CKD, it is AKI on CKD. In nowadays, most of the patients which we come across in the hospitals, they are AKI on chronic kidney disease. Part C AKI is quite rare nowadays, because many of the patients are having comorbidities of that I have mentioned already. And these patients do not know that they are going to having what is going to have their because they have already other problems. They ignore their new findings. So many of the patients come, they do not know that there is having an acute kidney injury inside them. It has been seen that CKD is also an important risk factor for AKI. A meta-analysis has shown that AKI in patients with diabetes or hypertension is more than that of the usual population. And as such, CKD is an independent risk factor for development of AKI. This systematic review of prediction models for AKI following major non-cardiac surgery and found that renal insufficiency was an important risk for AKI occurrence. So even other non-cardiac surgery and cardiac surgery, they are also in risk of development of AKI. But importantly, CKD adversely affects the outcome of the kidney AKI. That it has been shown that those who are having CKD with proteinuria, diabetes, hypertension, or other disease, there's a strong and independent risk factors for AKI and hospitalization and death. This slide has been shown that those who have having fresh AKI, they can go home with recovery. But those who have predisposing factors, having CKD earlier, there is more chance of ESRD or development of aggravation of the CKD, or even the more mortality and death. So CKD itself is a risk factors, as a bad prognostic factors, is a bad outcome for a new AKI in this type of patients. So with this background, if we have patients like this, a lady of 41 reported to emergency with nausea, vomiting, and diarrhea for last 5 days. She is passing scanty urine since yesterday. Her serum creatinine is 2.4. So this can be a scenario. We'll discuss how we should deal this. And second scenario could be, and Mr. X, 36 years of age, from Chattogram, serving in Saudi Arabia for last 8 years. And during his stay at Bangladesh, developed scanty reddish urine with pain in the both flanks, with fever, nausea, and vomiting. His creatinine is also 2.4. The patients can come in like this. A 23-year-old female reported with polyarthritis, facial rash, and fever for 3 months. And since last 7 days, her urine output becomes scanty and has developed generalized swelling of the whole body. And this serum creatinine is 2.4. She is dystic. The patient can be like this: a 70-year-old non-diabetic patient, hypertensive patient, peripheral artery disease, and ischemic cardiomyopathy with chronic kidney disease, having creatinine of 2.1, got admitted to coronary care unit with unstable angina and left ventricular failure. He is on IV furosemide, NORAD, vasopressin, along with other cardioactive drugs. His creatinine is 4 and referred for nephroconcentration. So these are the scenarios. There are many, but these are the common scenarios by which the AKI patients reports the feature that I have mentioned. So with all these features, as I have mentioned, then what I should do? So first thing that I should go for, is there any emergency in these patients which has to be done, which will be dealt immediately right now to save the patient's life? So is the patient is in shock? Is it hypotensive? Is the patient is having pulmonary edema, dyspnea? Is the patient still losing the fluid or blood? Is there any arrhythmia or bradycardia? Does the patient has uremia or encephalopathy? Is there acidosis? Is there ongoing sepsis? Is the patient is having colicky pain abdomen or bladder outlet obstructions? Or there is nothing in the clinical picture, but there is alarming biochemistry with acidosis, hyperkalemia, or a very high level of urea. But the patients can also present with abnormal ECG like features of hyperkalemia. The patient can present in the X-ray with pulmonary edema. So at the outset, in a patient of abnormal creatinine of acute onset, we have to go through this list whether the patient is having any emergency, and we have to manage at the outset. So if there is no emergency, so we have to then look for whether this AKI has happened outside before the kidney, that is pre-renal, or inside the kidney or renal, or after the kidney, that is post-renal. So as I said, I'll not go to the details of the cosmology. It could be hypovolemia, it could be hypotension and cardiogenic shock, it can be edema, edematosis like cardiac failure, hepatic failure, others. It can be hypoperfusion due to NSAID, vasodilators, and others, or all these things can lead to generalized localized reduction of the renal blood flow and reduced GFR and pre-renal AKI. But this can be due to totally renal, which could be glomerular like glomerulonephritis, which can be ANCA, SLE, or many things, which can be tubular like acute tubular necrosis, which is the most common cause. It can be interstitial like acute interstitial nephritis like pyelonephritis. It could be vascular event. So all this can lead to a renal cause of AKI, but this could be post-renal also. So which could be due to benign enlargement of the prostate, bilateral renal stones, obstructed urinary catheter, which is already in the hospital. Many a times we come across the patients is just in an unconscious patient, the bladder is full, catheter is clamped or catheter is obstructed. So there could be bladder stone obstructing the urethra, and there could be cancer in the bladder or prostate that can lead to obstruction of the urinary flow. So with this claims of causology, what we should have in a case of pre-renal AKI. These patients may have a history of excessive fluid loss, maybe in the form of hemorrhage, vomiting, diarrhea, or sweating, that all of you know. But many a times it happens that hospitalized patients may have insufficient replacement of fluids to cover ongoing or insensible loss, especially if there is restriction of fluid. This happens in the home also. The patients which are of CVA or some for other reasons, they are just hospice-like care in the house. They are on rice tube feeding. The fluid intake, many of the attendants, they remain outside, and the fluid replacement is not proper, so patients are not getting enough fluid. This happens in the hospital also and outside the hospital, obviously. But there is one more thing. Many a time patients get admitted with breathlessness because of the cardiac failure or fluid overload and others. And it happens that there is excessive diuresis because of the extra diuretics that we use. So we do produce pre-renal failure, especially in the patients who are in cardiac units because of the fluid overload, because of the pulmonia. The diuresis is so much that patient gets pre-renal failure. So there could be ongoing sepsis, burns. There could be major surgery just before the previous week, or pancreatitis. This patient usually presents with features of hypovolemia like thirst, dizziness, postural fatigue. Postural fatigue is very important because the patient is going to hypotension whenever he gets hypotension and vertigo. So any patients of AKI, when he or she gets vertigo and unsteady gait, is likely that this patient is having hypotension and going to have pre-renal failure. Sorry. As I said, congestive heart failure and cirrhosis liver can also lead to pre-renal AKI because of poor perfusion in the kidneys. In this type of patients, these patients are fluid overloaded. There is pulmonary edema, there is dependent edema, and many times there is ascites also. But even then, renal perfusion is less. So in these situations, there is pre-renal failure, pre-renal AKI, there's kidney perfusion is less, but the patient is overall fluid overloaded. And in this particular group of patients, fluid management is different and difficult. So, is the patient is lying flat? A patient of post-renal AKI will not remain, usually do not remain quiet. Either there is bladder obstruction or there is colic. He or she would shout or cry or call the doctors to do something. And in patients of renal AKI, there will be fluid overload. Likely this patient is having pulmonary edema and he or she cannot remain flat. So a patient lying flat in the bed comfortably is likely to be of pre-renal origin. So then we look for the features of dehydration like the sunken eyes, dry tongue, the inelastic skin, and definitely we look for the orthostatic hypotension and hypertension. A pre-renal AKI usually do not come with edema unless there is cardiac failure. And then we should look for the JVP. A renal AKI of renal origin will definitely have fluid overload and raised JVP, but AKI of pre-renal cannot have a raised JVP. And if the X-ray is available, that is a good clue. Glomerulonephritis or any other AKI of renal origin will have some form of fluid overload and may have pulmonary edema. And pre-renal AKI will never have pulmonary edema. What about IVC? Inferior vena cava is a good guide. It's a very important guide clinically if the amenities are there about the fluid status of the patient. Normally, the IVC diameter is less than 2.1 centimeter and it can be compressible. So if the compressibility is more than 50%, so this patient is not fluid overloaded. So any patients of AKI comes with, and if there is equation is there, and we can find there is good compressibility, is unlikely to be patients of renal origin. But if the patient is on ventilator, that can be also a good guide. Only 12% compressibility is indicative of, more than 12% compressibility is indicative of fluid overload. And obviously, if we can measure the central venous pressure, that is also a good guide for fluid overload or fluid deficit in pre-renal failure. So in case of pre-renal failure, we'll get the features of hypotension, hypovolemia, dehydration. So that is a good guide that the patient is still requires fluid. But in case of intrinsic or renal AKI, the things would be different. There will be cause of that renal AKI. There's something in the kidney that can be, these are the guides that the patient is going to have something inside the kidney, like fever, arthritis, rash, that is loin pain. This loin pain is because of the stressing of the renal capsule. Because of the nephritis, the kidney has been enlarged. So this capsule is enlarged, this excited, and there is loin pain. Obviously, because of the nephritis, the patients will have oliguria, then puffy face, then edema, then anasarca. And if the fluid develops inside the lung, either in the effusion form or in the pulmonary form, there will be shortness of breath. But all these patients, because of renopulmonary involvement like connective disease and others, there can be simultaneous respiratory problem and kidney problem. So if the patient presents with abnormal creatinine value, along with all these things, we should always think that this patient is having something inside the kidney. And in that situation, we should look, but what are the drugs that he is taking? Is there any invasive procedures has been done in the previous week? Have any contrast has been used over the last few days? It might happen that the patient had a profound diarrhea or patient having vomiting for some other reasons for a long time, and that has just been treated properly. So this patient has developed pre-renal failure, pre-renal AKI, that has caused ischemia to the kidney and leading to acute tubular necrosis. So it has become now a renal origin. So pre-renal failure, if cannot be treated properly for timely, then there will be necrosis of the tubular cells. So there will be acute tubular necrosis. In that case, the situation will become a renal origin now. So we should look for all these things that I have discussed, all the drugs, all the nephrotoxins, and the things that in most of the situation in the coronary care unit or the cardiac unit, patients comes with shock, because of the unstable engine or cardiogenic shock, and they do use the sympathomimetics and vasopressors. These vasopressors causes vasoconstrictions not only in the peripheral vessels, also intrarenal vessels. So because of this vasopressing effect, the kidney further gets poor perfusion, leading to aggravation of the aggravation of the poor perfusion, leading to further aggravation of the AKI. In situation, it might happen because nowadays there are a lot of programs are there. There are games. There are I mean the marathons. Even there are missile and processions in the roads. So any undue exercise can lead to rhabdomyolysis, and the patient may come with tender muscles, pain, and ultimately AKI. One thing we many times forgotten that in patients, many of the diabetic patients and hypertensions are on drugs like ACE inhibitors and receptor blockers. These drugs are very essential when their pressure is high. But whenever the patient comes with cardiogenic effect, shock, or something like that, these drugs may be further harmful in those situations, dilating the efferent vessels by vascular effect. They cause further reduction of the perfusion pressure, leading to AKI. So those ARB and ACE inhibitors are essential initially, but in those situations, they can be more harmful than the beneficial effects. এসান আমাকে শোনা যাচ্ছে?
Yes, sir, you are audible.
Okay. So after the pre-renal and renal, we have got something about the post-renal. So the patients of post-renal failure or AKI usually comes with genitourinary symptoms. Maybe these patients have genitourinary history of surgery in the past, history of passage of a stone in the past, history of urethral procedure in the past, was like urethral stricture and others. It is more common in the prostate, that is in older men, but it is also important to look for any malignancy in the prostate or bilateral stones that can cause obstruction in the both the ureters. Many times bladder cancer or bladder, I mean the bleeding can also cause obstruction in the urethra, leading to AKI also. But in post-renal situations, the common symptoms are difficulty voiding, there could be hematuria, there could be urinary colic, there could be passage of stones. But this is important. These post-renal patients usually are not dehydrated. They are also not fluid overloaded. If there is fluid overload, it is unlikely to be a post-renal cause. If there is dehydration, something other happened. But there is important, this bladder would be palpable. There can be palpable kidneys. So with all these things, all the histories, if we get these findings, that is palpable bladder or kidneys, or there is no features of fluid overloadation, likely the patient is having post-renal. So colic, palpable bladder or kidneys, no dehydration or fluid overload, likely we are dealing with a case of post-renal failure. So in any such patients, the common investigations, very common, say a routine urine examinations and all these things. I'll just touch upon these routine urine examinations today, because that is good enough in most of these situations to diagnose a case of AKI of which origin. So in case of pre-renal, the urine remains concentrated. The urinary osmolality is high because patient is dehydrated, there is no fluid in the body. So whatever amount is filtered, whatever water is filtered, whatever sodium is filtered, kidney, the tubules will try to reabsorb everything. So urine becomes highly osmolar. The sodium will be low. The fractional extent of sodium is also low. And in such situations, urine microscopy will not get anything because kidney has not suffered inside. Only the kidney has been not given the sufficient amount of fluid or blood. So the microscopy would be normal in case of pre-renal azotemia or pre-renal AKI. But if the pre-renal AKI persists for a longer time, as I said, so because of the hypoperfusion, because of the hypovolemia, because of the low pressure, the tubular cells will get ischemic and necrosed. So there will be acute tubular necrosis. So there will be, sorry, this would be the low osmolality because urine cannot be concentrated. Sodium will be also high. This fractional excretion of sodium will be also high. And microscopy may show muddy brown, this type of granular cast. This granular cast comes from the tubular epithelial cells. The epithelial cells broken down and becomes granular appearance, but the appearance is dirty, muddy color. So in ATN, their urinary osmolality will be low, sodium will be high, fractional excretion of sodium will be high because kidney cannot concentrate, kidney cannot reabsorb, and there will be epithelial casts which will become granular casts ultimately. But in case of AGN, in case of renal AKI, what happened? The glomeruli will become involved, so there will be leakage of blood, so urine will become reddish. If the urine remains inside the bladder for a quite longer time, they will become coca color. But if the amount of blood is less, it can come as smoky urine. A simple dipstick test or a heat test will prove that there is albumin in the urine because blood is leaking. The most important protein in the blood is albumin. So albumin will be in the urine, and that can be tested by the albustix or heat coagulation test. As the glomeruli has been torn, so there will be leaking of blood leading to plenty of RBC because blood is full of millions of RBC. So there will be plenty of RBC. And this RBC, as it is going through the tubules, it will become distorted. So this RBC's shape will be dysmorphic. And whenever these RBC is going through the tubules, they have been entangled with the Tam-Horsfall protein and forming casts. So there will be RBC cast, like this red one. This RBC cast would be there. And the RBC cast, if the RBC are broken down, then the cell wall will come like this granular cast. Only few granules will be seen, that will be the cell wall of the RBCs. So in AGN, a simple dipstick test can also prove that his color is reddish. I'll get albumin, I'll get RBC in the urine. So these things can prove that this patient is having a nephritis. And if I see under the microscope, there can be dysmorphic RBC, there can be RBC cast or granular cast. But if it is acute interstitial nephritis like acute pyelonephritis, so there can be bleeding also. So this urine can be also reddish. This can be purulent or cloudy, and there could be foul smell. As there is an infection, so there will be plenty of pus cells. But the third one will be plenty or few RBC would be there, not pus cells. And these pus cells can form cast inside the tubules. There will be a WBC cast. So WBC cast is almost pathognomic of something and acute interstitial nephritis or acute pyelonephritis. So reddish or cloudy urine, plenty of pus cells, few RBC, and WBC cast will indicate of acute interstitial nephritis or pyelonephritis. In post-renal AKI, so either there is a trauma or there is stone or there is tumor or there is a or blood prostatic involvement is there. So urine can be normal, or if there is a leaking of blood, there will be reddish. These RBC will be seen in the microscope, and as this RBC has not passed through the tubules, whenever RBC is passing through the tubules, their skin, there is cell surface, this cell membrane become distorted, so they become dysmorphic. But in post-renal case, the bleeding comes from this, either from the minor calyces or from the major calyces or the pelvis or the ureter or bladder. They need not to pass through the tubules, so they are cells remain isomorphic, and there may be the as the blood is leaking, there will be few WBC also. So by simple examination of the urine, a knowledgeable person can very well diagnose this patient with the history of background history, whether any fluid loss or blood loss, whether any history of drug, whether any history of infection, whether any history of connective disease, or any incidence of post-renal involvement. Then urine by naked examination, or by dipstick test, or by microscopy, a diagnosis of AKI is not very difficult. So that what I have discussed so far has been in the table form here. So FEN in intrinsic form, the FEN would be, and that is in TN, or in nephritis form, the sodium will be high, FEN will be high, osmolality will be low, and there will be active urinary sediment that I have discussed. So let us see the scenario 1. So this lady has presented with vomiting and diarrhea for the last 3 days. And because of this fluid loss, she has having a scanty urine. So is likely this patient is having pre-renal failure. So in this situation, what is the expected clinical findings? Should he have high BP? No. Should he have bilateral lung crackles? Cannot be, because the patient is fluid deficit. What can happen? This patient may be a postural hypotension or systemic hypotension. Then what we should do? Should we give furosemide because patient is having less urine output? No, we can't give furosemide. Should we give ciprofloxacin? No, that is nephrotoxic also. What should we do? We should give rapid IV fluid. 1 to 3 liters rapidly. Since scenario 2, Mr. X, who stays in Saudi Arabia, you know that most of the our citizen who stays in Middle East, because of the hot, humid environment, the urine becomes volume is less, and many of the patients, many of our citizens develop renal stones, and many of them are bilateral renal stones. And this patient also have the same problem. Patient has got obstructed stones in the ureter or in the urethra, leading to nausea, vomiting, and that stone produced infection, leading to fever. This obstruction has produced bilateral hydronephrosis and produced bilateral flank pain. So this is an obstructive cause of AKI. So what should be the findings in these patients? Postural hypertension? Unlikely, because patient is not dehydrated. Dyspnea? No, fluid cannot be. This patient is not having fluid overload, so dyspnea cannot be. What can be? Yes, this patient can have similar spells in the past. This patient has got hematuria, could be. And he has history of passage of gravels in the past. These things can be there. On examination, can he have edema? No. Can he have postural hypertension? No. Bibasal capitations? No. Because this the fluid status is normal. What can have? He can have palpable kidney, palpable bladder. In the scenario 3, that is patient with polyarthritis, facial rash, fever for 3 months. Since last 7 days, his urine output becomes scanty and has developed generalized swelling of the whole body. She is dyspneic. This picture very well says that this is patient having connective disease, either SLE or vasculitis. And over the last 3 months, he has not been treated well. Now his kidney is involved. So there is a features of nephritis, and that has led to fluid overload, polyureal fluid overload, and the patient got this thing. So this patient is what we expect in this type of patients. Does she can have portal hypertension? No, because there is fluid overload. This patient might have hypertension. Full bladder, unlikely, because patient is oliguric, bladder is not should not be palpable. What we can have, there is RBC cast in the urine and RBC in the urine. There will be albumin in the urine. Plenty of WBC in the urine, yes or no? No, because we don't expect an infection there. Of course, secondary infection can be there. What we should give this patient? Should we give IV saline? No, because patient is already fluid overload. Should we give furosemide? Yes, this is applicable here. Fluid restriction, okay. Steroid, immunoactive drugs, yes, there is chance of we should consider all these things. So let us have the scenario 4. This patient of elderly man, diabetic, hypertension, peripheral disease, ischemic cardiomyopathy with known CKD, got admitted to CCU with unstable angina, left ventricular failure, and shock. So what not? So this patient, because of the shock, because of the poor function of cardiomyopathy, patient has developed further aggravation of his renal impairment. So he is on IV furosemide already. He is on noradrenaline, vasopressin, along with other cardioactive drugs like nitrates, like so his creatinine is now 4 milligram per deciliter. He is on high flow mask. So this patient has referred for consultation to the nephrologist. Then what we should do, what is expected? Obviously this patient is hypotensive, is already fluid overload and pulmonary edema. So these are less important here. Pyuria, hematuria could be there because this patient can have secondary infection. This patient might have been catheterized, so there may be hematuria. But per se, this patient should not have pyuria or hematuria. In these critical patients, what should be done? I know that the patient is, this NORAD will cause further vasopressin. Vasopressin will get further contraction of the renal vessels, but I can't stop this. This IV furosemide, this patient is in shock. But IV furosemide is there, that will cause further damage, further lower of the blood pressure. But to save his lung, this IV furosemide has to be accepted. So in sometimes, as a nephrologist, in situations, I have to accept all these things. This furosemide I have to accept, I have to swallow. The NORAD vasopressin I have to swallow to save the patient's lung and heart. So only thing, yes, furosemide dose titration has to be done. Fluid restriction is done. The steroid has no role. But if the cardiologist says that they want to add sacubitril and valsartan in these type of patients, then even then I have to say, okay, to increase the cardiac contractility, you can go for this. But you have, in that situation, you may have to sacrifice the kidneys. Sometimes it happens, to save the heart, we have to sacrifice the kidney sometimes. So after the evaluation, it has been found that this patient is having pre-renal failure. So we have to give fluid. How much? The patient may have a deficit of 3 liters or more. So they give fluid rapidly till the blood pressure comes out, or the patient develops some features of fluid overload or breathing difficulties. So, and the patient got urine output or not. If even after the sufficient rehydration, the tongue has become wet, the eyes has become normal, there's no sunken eyes, the pulse has gone, blood pressure is gone up, but the patient has not developed urine output, so then you should stop the infusion of the fluid. So after review the patient's fluid status, volume status by your clinical judgment or IVC or JVP, then guide the fluid that how much you should give. But as I said, in cardiac patients, whatever may be the prerenal origin, you can't give fluid. In prerenal failure, there is a role of vasopressors. Definitely, if the blood pressure remains low, kidney will suffer more. So, fluid infusion may take some times, or there may be sepsis. So, in some situations, with fluid, we may have to give vasopressors. The mean arterial pressure is just 60 is enough. Mean arterial pressure is just 60 is enough to maintain the renal perfusion. As I said, in cardiac patients or in liver patients, many times these ionotropes, diuretics, and cardiac drugs, I have to accept. So in those situations, to get rid of the fluid overload, many times the nephrologist has to give renal replacement therapy earlier than the usual case. There are options that only fluid can be removed by dialysis. So this type of patients may be benefited by early dialysis. So after the resuscitation of prerenal failure, if the patient's urine output is there, so first class patient has been saved. In intrinsic failure, it depends upon the cause of what is the cause, what is the etiology. If it is assumed that the prerenal failure is still continuing, like the dehydration is continuing still, we have to adjust the fluid. But if after the fluid adjustment or the patient is voluble, then there is a role of diuretics. One thing is that these diuretics will not improve the kidney status. The diuretics will not recover the patient faster, but the diuretics, if is active, effective, it can manage the patient's fluid status. He can take some food, he can take some drinks, we can give some IV medications also. So diuretics is effective if the urine output is there. If the diuretics is not effective, there is no urine, there is no role of diuretics. As in our third case, is the patients of any of the glomerulonephritis origin or vasculitis origin or any other patients who require cytotoxic agents or corticosteroids or immunomodifying drugs, that has to be considered seriously, and if possible after biopsy. How much diuretics can be given? A starting dose can be 80, but a bolus dose of 200 milligram can be also given if there is chance of urine output, chance of urine production is there. But in a case of diuretic refractory state, after giving sufficient amount of diuretics, how much? It can be 600 milligram a day. Even after this amount, after 24 hours, there is no urine output, so we should not go for further diuretics. And if there is features of pulmonary edema or there is volume overload, the patient should get renal replacement therapy or dialysis first. So in such cases, we do have always some abnormal electrolytes, which could be potassium, which can be phosphate, which can be magnesium, or can be uric acid. But many times we get hyponatremia also, but this hyponatremia is dilutional, and that is managed by fluid restrictions, and usually there is no problem. But acidosis should be addressed very seriously. Unless the acidosis can be corrected rapidly if it is ketoacidosis. So target bicarbonate level should be more than 20. So that should be given IV sodium bicarb so that the patient's acidosis is corrected. Remember one thing, all the medicines has to be titrated according to the severity of the kidney problem. So whatever antibiotic we give, whatever antihypertensive we give, everything has to be titrated against the serum creatinine level or the GFR level. So every drug has to be monitored, has to be given according to the dose depending on the GFR of the patient. And the management of nutrition is also very important. One thing I must make clear, but a single patient will not have all the abnormalities. The same patient will not have hyperkalemia. The same patient will not have hyponatremia. The same patient will not have hyperphosphatemia. So every patient has to be assessed according to their requirement. A patient might have diuretic-induced hypokalemia. So if we restrict fruits and others, we will get further problem with the potassium. So if the patient is having potassium more than 4.5, it is better to restrict. If the potassium is less than 4.5, there is no need to restrict the potassium. Fluid intake, that's why the diuretic is important. If there is diuretic can produce some urine, if 1 glass urine means patient can take 1 glass of water. So fluid intake depends on the output and the volume status. Remember one thing, to produce edema in any particular adult person of 70 kg, it requires 4 liters of extra fluid. So the patient who is already edematous having extra 4 liters of fluid in his body. So though we say the fluid should be 500 plus output to neutralize. In fact, in clinical practice, to get rid of edema, patient should be on a negative balance. But if we think this patient is having obstructive origin, you palpate the bladder, or if there is doubt, give a catheter to get rid of whether there is any obstruction or not. If it is so, get the urological or surgical consultation early. So even after the managements, the patient has to be under you to follow up the patient so that the patients develop any features of uremia or the patient is developing any features of complications. So it is better to refer if the patient deteriorates to have better to consider renal replacement therapy in the coming days. So you all know, just to sum up, these are the indications of renal replacement therapy, that is dialysis. Whether this is patient having pulmonary edema, acidosis, hyperkalemia, they are all you know. Remember this is not a subject of today, but renal replacement therapy or dialysis of different types. Nowadays, no patient is refractory for dialysis. Every patient can be given with dialysis, whether in shock, whether in bleeding, whether any sepsis or anything. So there are modalities of treatment of dialysis that suit to a particular type of patients. So I am not going in details of that, but if the patient requires dialysis, whatever may be, he may be in cardiogenic shock, he may be in septic shock, he may be on hypovolemic shock, whatever it is, dialysis can be there to save the life. Thank you. I have tried to just give an overview of the situation of AKI. Is not a detailed depth discussion, so that the most of the internists, most of the trainees can have an idea about how to approach a patient of AKI. Thank you all. Thank you very much.
Thank you very much, sir. That was such a learning experience. And our audience should also notice how to make a presentation. and how to calmly explain everything so nicely. Thank you very much, sir. Now it is the question answer session. The session is open for the participants. If you want, you can ask your questions directly to our presenter and to our chairperson as well.
আমি একটু ইন্টারফেয়ার করি
Please
স্যার,
raise
আপনার
hands.
স্লাইডটা যদি
Yes,
একটু অফ
Dr.
করে দেন
Islam.
স্যার। স্যার আপনার একটু স্লাইড শেয়ারটা অফ করে দিবেন স্যার কাইন্ডলি।
Yes, thank you.
Sir. Dear participants.
নৌশিন, আমি একটু বলি।
Yes, sir. জি স্যার,
তুমি
অবশ্যই।
প্রশ্ন নেওয়ার আগে। So
জি।
thank you, Mamun, and I'm so hello. Acha. So I think at a short time he has done an excellent job summarizing such a huge topic. AKI actually a hospital issue. So what he's discussed actually, we do the same thing in the United States. When somebody got AKI in the hospital, how we handle it. But the large majority of the patient, when they're seeing patient in their office, they should also suspect AKI. Why? Because of risk factors. And I think we should make sure that we should not cause AKI, because AKI and CKD sometimes is caused by the physician. So they are giving many medications unnecessarily or long time can cause kidney damage. How do we know? So first thing we should know by knowing that this medication can, the risk factors. Second thing that we don't use, like I was talking to Dr. Mamun Mustafi, that we don't use as much dipstick of the urine in the doctor's office. Here we do it all the time. So suppose a patient came to you, and patient is on any medications, and you did the dipstick because you cannot do serum creatinine right away. And serum creatinine also is so important that if serum creatinine is higher than normal, just a little bit higher than normal, that means you already lost 50% of kidney injury. আমার ছবিটা frozen হয়ে আছে, নৌশিনকে দেখা যাচ্ছে, and I'm just frozen. So if I can say I'm talking, it will be better than just showing Noushin. I know she's beautiful.
Sir,
So
you are visible to us. We can see you.
okay, so I cannot see myself, so that's what I'm not sure. Anyway, so I was thinking, so most important thing is that first we should suspect, we should curtail medications, not only NSAID, even ACE inhibitors on CKD, and also the diet sometimes can cause a lot of issues. So that's one thing. We should use more dipstick in the office. If we give any medication, then you should think about repeating the kidney test, like creatinine, potassium. Like sometimes we give diuretics. Within 4 weeks, we should test the potassium. There's hypokalemia, which can actually cause AKI too. We should treat that. So AKI is a hospital illness, and Mamun very nicely described everything. One thing I like to add, that the peritoneal dialysis is underutilized. If it is underutilized, in some hospital we cannot do CRRT or we cannot do hemodialysis. So some remote corner or some district hospital, if we can teach them how to do acute PD, then we can also save a load to the tertiary hospitals and also teach them. So I will stop here and see what questions the audience has. Thank you.
Thank you very much, sir. We will hear from you again. Now I am asking our participants, especially now Dr. Yusuf Ali wants to ask his question directly. Dr. Yusuf, please put your question to the panelists. Live question from Dr. Yusuf Ali. Thank you.
Assalamu alaikum, sir. First of all, I like to thanks Professor Brigadier General Mamun Mustafi, sir. Sir, it was a wonderful presentation, sir. Actually, from our aspect as a junior doctor, I think the presentation should be like this, and this is the way approach, sir, how you have shown how our teachers, we juniors in future should present should present a topic like this way, sir. It was just mind-blowing topics and presentation by you. Sir, I have a question regarding this, sir. AKI and CKD is very much common in our country due to for several reasons, due to our fault and use of long-term medicine and so many causes in Bangladesh, sir. In your perspective, sir, to define AKI, sometimes, sir, oliguria or anuria or sometimes a drug especially, sir. I want to know that there may be non-oliguric AKI. That is, sir, acute interstitial nephritis. In that cases, sir, fluid management and fluid assessment, sir, what will be the approach actually? What I mentioned that acute interstitial nephritis, like due to drug induced, that you have shown already. In that cases, sir, definition of AKI is also hampered, and management is little bit confusing, sir. So would you clarify non-oliguric AKI due to interstitial nephritis sometime?
Thank you, Dr. Yusuf. I got very happy that so many of you has joined today. Sometimes I got is 160 participants. That is enormous. Hats off to the BD physicians and all the participants. You made the program so nicely. In fact, the AKI diagnosis has got two criteria. One is urinary output criteria and one is creatine-based criteria. So either of the two, if it is there, it should be as case of AKI. As I said in the first slide, as if the creatinine is just 0.3 milligram above that of the previous value over last 48 hours, that can make you diagnosis AKI. Or over the last 7 days, if it is more than 1.5 times of the previous value, say a value of one was there, his previous value, now it is 1.6. That is good enough to make the diagnosis of AKI. So depending upon the time and creatinine, you can make the diagnosis of AKI. Or if depending upon the urine output, if it is less than 0.5 ml per kg per hour for 6 hours. As I said, in your patients, it is non-allergic, so urine criteria does not fall here. But if urine criteria, as I said, 1 glass urine in 12 hours, it should be, if it is not less than one glass, that should be suffice to make it a case of AKI. So diagnosis of AKI can be on creatine based or urine based. Now the questions of fluid management definitely easier if the production urine is there. So you need not to worry about the fluid intake. What we usually get alarm that if the patient cannot pass urine, if there is no urine production, we have to restrict the fluid. So in non-oliguric patients, there should not be any restriction of the fluid. Thank you very much.
Thank you, sir. If Zia sir would like to compensate anything to the answer. Otherwise, we are moving on to the next
No,
live.
I think he explained it very nicely. The problem is it's a important subject, and urine, that's why sometimes the urine volume is important at home, because we don't know the serum creatinine. Hospitalized patient, we always do serum creatinine daily, and we know that non-oliguric ATI doesn't have to be interstitial nephritis. It can happen with ischemic ATN, like rhabdomyolysis, and also dye-induced ATN. Even in this case, your PINA can be like a pre-renal. But what's happening? You're having good urine output, but serum creatinine is going up every day. But good thing he mentioned already that it looks like it's a less severe, and there's a better chance of this patient recovery faster. So why? Because maybe the tubular injury is less than the oliguric ATN. So that's why maybe, but that's what is quite known. So the management also he mentioned properly, but most important thing that it doesn't have to be interstitial nephritis. It can be any ATN, especially rhabdo or dye-induced ATN or ischemic ATN. If it's a less injury, you can have non-oliguric component of the ATN. Thank you.
Thank you, sir.
There are more two questions. One is ACE inhibitors or ERB stopped in a patient with AKI who used to get yes. It is better to stop these ACE inhibitors or receptor blockers at the event of AKI. Then which is best for serum creatinine or EGFR? The KDIGO guidelines says it is serum creatinine because GFR has to be calculated, is not authenticated on many a times. So it is serum creatinine based. And urea should not be used in the diagnosis because urea can be raised by some other regions. Thank you. Any other questions?
Thank you, sir. Yes, I have some more questions. And Dr. Ikram is waiting to put his question live. Dr. Ikram, please go on with your question.
Dr. Ikram, please unmute yourself. Dr. Shahidul Islam. Okay, Dr. Ikram, then Shahidul Islam Bhuya. Dr. Ikram, please.
Assalamu alaikum. Can you hear me?
Walaikum assalam.
Yes.
Yes, it's very loud and clear.
Yes, sir. Thank you for your nice presentation, sir. We have learned a lot from this presentation. I have a question, sir, that in case of fluid overloaded patients and fluid overloaded AKI, which form of sodium bicarbonate in case of metabolic acidosis we should prescribe? As we know that IV sodium bicarbonate is more likely to causes of fluid overload more. In that case, should we use the oral form for the treatment of metabolic acidosis?
No, whenever these sodium acidosis need to be managed urgently, it is always intravenous.
Okay, sir. Okay, sir. Thank you, sir.
Yeah, thank you.
Thank you, Dr. Ikram. Sir, we have some more questions. Dr. Morshed asked, how dyslipidemia can cause AKI? And there is another question put by Dr. Maqsuda Parveen, that is there is any relationship with non-alcoholic steatosis with kidney injury?
First question.
Okay, sir. How dyslipidemia causes AKI?
No, dyslipidemia do not cause AKI. Dyslipidemia is a risk factors for AKI because these patients are having atherosclerotic diseases inside the kidney, and any low form of hypotension will cause development of AKI or aggravation of the previous renal status. Next question.
Exactly, sir. Next question is there any relationship of non-alcoholic steatosis with CKD or kidney injury?
It has been seen that the chronic liver disease is the risk factors for development of AKI. Chronic steatosis, I'm not sure. I need to, you can communicate with me. I'll make it clear soon. Jia bhai, if you want to add something here.
Not really, because the problem is all the organs, they talk to each other. So even though we didn't know before, we know that if a dysfunction happens in the liver, it affects the kidneys and the cardiorenal, hepatorenal. So there may be some relationship, but it's not clear yet. Thank you. But statin also can cause AKI with rhabdomyolysis. So even though the lipidemia directly doesn't cause it, the treatment can cause it. So if somebody is on a statin, if somebody having muscle pain, you better check the creatinine and the CPK, make sure that we are not giving an AKI with the medications.
Absolutely, sir. Thank you. Sir, Dr. Hassan is very much.
Okay, Shahidul Islam Bhuya, please.
Yes, Dr. Shahidul Islam Bhuya.
Thank you,
One
sir.
minute. Ami, just now I got an article online. This non-alcoholic fatty liver disease promotes the progression of chronic disease. Vice versa, acute kidney injury endorses the induction of progression of liver disease dysfunction. There is definite relation, but it is a speculation. There is definite relation is there. Thank you very much.
Okay, thank you, sir. Sir, অনেক ধন্যবাদ স্যার, আসলে এক্সট্রাঅর্ডিনারি প্রেজেন্টেশন আমাদের জন্য আর কি স্যার। স্যার আমার একটা সাপ্লিমেন্ট কোশ্চেন, আপনি বলতেছিলেন স্যার একেআই তে আমরা এসি ইনহিবিটরস বা এআরবি গুলা টেম্পোরারি স্টপ করব স্যার। স্যার এখানে কি কোনো স্পেসিফিক লিমিট আছে যে ক্রিয়েটিনিন লেভেল অথবা ক্রিয়েটিনিন লেভেল স্পেশালি স্যার আমরা যেমন 1.5 বা 1.67 আমরা নরমালি বলি যে স্পেশালি স্যার বিশেষ করে ডায়াবেটিক কিডনি ডিজিজ যদি থাকে পেশেন্ট গুলাতে, যে পেশেন্টের সেক্ষেত্রে আমরা স্যার একেআই হলেও মানে লেভেলটা যদি স্যার ক্রিয়েটিনের স্পেসিফিক লিমিটটা জানতে চাচ্ছিলাম স্যার। এরকম কিছু আছে যে এরকম হলে আমরা ডেফিনেটলি এতদিনের জন্য বন্ধ রাখবো, আবার যদি ডেক্লাইন করতে থাকে কিডনি ফাংশনটা ইমপ্রুভ করতে থাকবে এবং ক্রিয়েটিনিনটা যদি আবার কমে আসতে থাকে স্যার কতটুকু হলে আমরা আবার রিস্টার্ট করতে পারবো, এবং এটা টেন্টেটিভ স্যার কতদিন লাগতে পারে স্যার? প্র্যাকটিক্যালি স্যার আমরা যেটা ফেস করি আর কি স্যার।
এক্স্যাক্টলি, ভেরি নাইস, ভেরি নাইস। এটা রিয়েল প্র্যাকটিক্যাল প্রবলেম। এখানে আমি জাস্ট দুটো কথা বলতে চাচ্ছি যে এটা ডিপেন্ডস আপন দি পেশেন্টসের ভলিউম স্ট্যাটাস, দ্যাট ইজ ওয়েদার দেয়ার ইজ পেশেন্টের কোনো হাইপোটেনশন হাইপোভলিমিয়া হওয়ার কোনো চান্স আছে কিনা। যদি হয় তাহলে এই এফারেন্ট আর্টিওলটা ডাইলেট করার ফলে পেশেন্টের ইন্ট্রাগ্লোমুলার প্রেশার কমে গিয়ে আরো পারফিউশন আরো ফিল্ট্রেশন কম হবে। সো যদি ব্লাড প্রেশার খুব ভালো থাকে তাহলে হয়তো কন্টিনিউ করা যেতে পারে, বাট তখন ইস্যু আসবে পটাশিয়ামের লেভেলটা। সো অ্যাজ আই সেড, পটাশিয়াম যদি 4.5 এর উপরে থাকে তাহলে এগুলো সব বন্ধ করাই ভালো, কারণ আমরা হয়তো আবার শুরু করতে পারবো। পেশেন্ট যখন রেনাল ফাংশন রিস্টার্ট করবে তখন আমরা হয়তো রিস্টার্ট করতে পারবো। সো ভলিউম স্ট্যাটাস অ্যান্ড পটাশিয়াম স্ট্যাটাস উইল গাইড ইউ যে এটা স্টপ করব নাকি বন্ধ, মানে কমাবো নাকি রিস্টার্ট করব। আমার মনে হয় এইভাবে প্রসিড করলে ক্লিনিক্যালি সুবিধা হবে। থ্যাংক ইউ, অনেক ধন্যবাদ।
Thank you very much, sir. This is a really practical problem. I would like to request Dr. Zia sir if he would like to add something to this. Specifically, sir, there are some drugs like metformin, and then there are some other drugs that these AKI patients need, but we are really reluctant to start them because we are afraid that this will increase the creatinine. So what to do then?
Most important thing is that AKI, it should be reversible. So during AKI, we should not give any medication like metformin or ACE inhibitors that is not a urgent medicine, life-saving medicine. So we should stop it because we don't know whether it's causing intestinal nephritis or just hemodynamic effect, or it's causing metabolic acidosis and this and that. So yes, during AKI, it's better to stop medication which is not urgent until we see the recovery of the AKI, because AKI is a hospital diagnosis. So patient is in the hospital, so we're doing the test every day. But I'm talking about, my major concern is in a big outpatient, how can you diagnose AKI when there is no symptoms? So these are the issues that we should discuss in another setting, that what medication, if you give a medication, then how can you check, especially introducing the dipstick in the office. I have patient who can have a little albuminuria or hematuria, and they have no idea. And then you do the ultrasound, there's a cancer sitting in the kidney or the bladder. And there are patient who is not feeling well, and you find that they have a ketonuria. This patient is having a DKA. So a lot of things we can diagnose with a little dipstick in your office, and then we can refer the patient to your specialist. But during the AKI that Mamun mentioned very nicely, all these things we also do the same thing in this country. And most important thing, that the prevention, if you want to do a dye study to a CKD patient, you have to make sure the patient is hydrated. If you want to do a major surgery to a patient with CKD, because AKI on CKD is much more common that you mentioned than pure AKI. When pure AKI happen, they're sick like a dog. Because pure AKI happen with rhabdo, with sepsis, you'll admit the patient definitely. But when patient develop AKI on CKD, they're mostly asymptomatic. And that is our job, to identify it and remove the component of AKI on that CKD patient. So that's what I like to add. And thank you very much again. And thanks, Noshin and Mamun, you did a great job. And I'm sure so many people are watching. So there's interest now. The same is so important. I'll be happy to discuss in the future if needed. But again, thank you all for allowing me to be part of this session. Thank you.
Thank you, sir. I had some few more questions actually, if you would allow me, sir. That is
one more thing. Professor Ziauddin is in States. Oh, his Jumma prayer is just knocking. So he has to leave because of this Jummah prayer. So we have got no problem. We can continue, but
Yes, sir.
Professor Ziauddin sir has to go. Thank you জিয়া ভাই, আপনাকে অনেক অনেক ধন্যবাদ, প্রাণ ঢালার শুভেচ্ছা। আপনি এত ব্যস্ততার মধ্যেও আমাদেরকে সময় দিয়েছেন। That's a great thing for there's great achievement for us and great donation to us also. Thank you জিয়া ভাই. Have a long life.
Thank
Have
you.
a safe life.
Thank you, sir. Jazakallahu khairan. Sir, now if I may proceed. Sir, I personally had this question that
আচ্ছা,
whenever
এখানে
we
দুটো
send,
কোশ্চেন আছে নওশীন, আমি একটুখানি কথা বলে নেই। এখানে একটা কোশ্চেন আছে যে অ্যালবুমিন যদি যায় তাহলে প্রোটিন রেস্ট্রিকশন করাটা ঠিক হবে কিনা। ইনফ্যাক্ট আমি যেটা আমি অনেক সময় বলি, কারণ আমাদের শরীরের মোস্ট অফ দি হরমোনস অ্যান্ড মোস্ট অফ দি এনজাইমস কিন্তু এই অ্যামাইনো অ্যাসিড দিয়ে তৈরি। তো প্রোটিন যদি আমরা একেবারে বন্ধ করে দেই তাহলে এগুলো কোত্থেকে আসবে? তখন এগুলো মাসলগুলো ভাঙবে, মাসলগুলো ভেঙে তখন ওয়েস্টিং তৈরি হয়ে যাবে। সুতরাং প্রোটিন আমাদেরকে দিতে হবে। সেটা আরো একটা ইম্পর্টেন্ট আছে, যখন কোনো পেশেন্টের সেপসিস হয়, যখন পেশেন্টের র্যাবডোমায়োলাইসিস হয়, যখন হাইপার ক্যাটাবলিজম হয়, তখন এই প্রোটিন রিকোয়ারমেন্ট আরো বেড়ে যায়। সুতরাং একেআই এর ক্ষেত্রে অনেক সময় আমরা এই সমস্ত ক্ষেত্রে আমরা প্রোটিন রেস্ট্রিকশন করি না, তবে যেটা দেই সেটা হলো খুব হাই ক্লাস প্রোটিন, ডিমই খেতে বলি, বাকি সবকিছু অ্যাভয়েড করি। আবার যারা ভেজিটেরিয়ান তাদের ক্ষেত্রে কিন্তু আবার যদি ডায়েল নিষেধ করা হয় তাহলে আরেকটা ক্ষতিকর কারণ হয়। সুতরাং ওই প্রত্যেকটা পেশেন্টই ডিফারেন্ট, ওইভাবে আলাদা করে তাকে, কিন্তু হ্যাঁ, যদি বেশি প্রোটিন দেই আমরা তাহলে কিন্তু এই প্রোটিনটা ব্রেকডাউন হয়ে ক্রিয়েটিন তৈরি হবে, তখন আরো অ্যাজিওটোমিয়া বাড়বে। সুতরাং এটা টু বি ব্যালেন্সড, যে কতটা বেশি কতটা কম দিব। আচ্ছা, আরেকটা ইম্পর্টেন্ট ভালো কোশ্চেন আছে যে পিপিআই ইন একেআই। তো আমরা সবাই জানি আজকাল যে আসলে মোস্ট অফ দি পিপিআই কজেস অ্যাকুট ইন্টারস্টিশিয়াল নেফ্রাইটিস, ইভেন ক্রনিক ইন্টারস্টিশিয়াল নেফ্রাইটিস। সুতরাং পিপিআই ইজ এ ভেরি নোটোরিয়াস ড্রাগ, ভেরি ডেঞ্জারাস ড্রাগ। আনলেস ইউ থিঙ্ক দ্যাট আমাকে এটা দিতে হবে, ইউ শুড নট গিভ। অ্যান্ড একটা কথা বলা আছে যে হ্যাঁ, ফ্যামোটিডিন হয়তো এটা একুইডিস্ট্রিনটা কম করে। সো ইন দ্যাট সিচুয়েশনস আমার মনে হয় ফ্যামোটিডিন আমরা যেটা আজকাল প্রেফার করি সেটা ফ্যামোটিডিন, অ্যান্ড টু সাম এক্সটেন্ট ডেক্সট্রান্সোপ্রাজল ক্যান বি অলসো ইউজড ফ্রেন্ডলি। নাওএডেজ যে ভক্সো জন্য একটা কি আসছে, এটা কিন্তু খুবই
Vonoprazole.
নোটোরিয়াস ফর কিডনি, সুতরাং বি অ্যাওয়ার অফ দিস ড্রাগ, এটা কিন্তু কিডনির জন্য সেফ না। খুব ভালো দুটো কোশ্চেন আসছে, ভেরি গুড, থ্যাংক ইউ ভেরি মাচ। আচ্ছা,
স্যার,
আরেকটা,
এখানে একটা স্যার আমার সম্পূরক কোয়েশ্চেন ছিল।
হ্যাঁ,
আমরা যখন এই কিডনি বিভাগে রেফারেল দেই যে পেশেন্টের একেআই ডেভেলপ করেছে, এখন কি করব, পেশেন্টের ফার্স্টে স্যার ওমিপ্রাজল এবং অন্যান্য নেফ্রোটক্সিক ড্রাগ বন্ধ করা হয়। কিন্তু আমি যেহেতু এখন কার্ডিওলজি ডিপার্টমেন্টে আছি, দেখা যায় যে আমরা যেসব ড্রাগস দিচ্ছি সেটার কারণেও ব্লিডিং রিস্ক বেড়ে যায়। পেশেন্টের আগের পিইউডি হিস্ট্রি থাকলে পিপিআইটা বন্ধ করা যায় না। সেক্ষেত্রে স্যার এটা কি ফার্স্ট ডোজেই এআইএন মানে অ্যাকিউট ইন্টারস্টিশিয়াল নেফ্রাইটিস করে পেশেন্টের আরো বেশি ক্ষতি করতে পারে, নাকি আমি চাইলে এটা চালাতে পারি, অথবা যদি ফ্যামোট্যাক অ্যাভেলেবল না থাকে সেক্ষেত্রে পিপিআই, স্যার আপনি একটা বললেন যে ইউজ করা যেতে পারে ডেক্সল্যান্সোপ্রাজল, সেক্ষেত্রে ক্লিনিক্যালি আমরা আসলে কি করব?
ইনফ্যাক্ট যে পেশেন্টটা বছর পর বছর পিপিআই পেয়ে আসছে সে তো নতুন করে আসলে হবে, তখন কার্ডিয়াক ইভেন্টটাই বেশি ইম্পর্টেন্ট। আমি
জি
একটু
স্যার।
আগে বলেছি না যে আমাকে কার্ডিয়াক অনেক ওষুধ আমাকে অ্যাকসেপ্ট করতে হয় যে পেশেন্টের হার্ট ভালো রাখার জন্য। তো ওই ক্ষেত্রে দ্যাট ইজ নট ভেরি ইম্পর্টেন্ট ইস্যু যে তাকে আমি প্যান্টোপ্রাজল থেকে ফ্যামোটিডিনে আসবো, বিকজ সে গত কয়েক বছর ধরেই খেয়ে আসছে। ওই ক্ষেত্রে এটা কোনো বড় কোনো ইস্যু না, জাস্ট কন্টিনিউ, পেশেন্ট যেন সেফার থাকে। সুতরাং ওটা তখন বন্ধ না করে আগেরটা কন্টিনিউ করাই বেটার। আনলেস এখন এমন হতে পারে হসপিটাল পেশেন্ট, আজকাল তো পেশেন্টের অ্যাটেন্ডেন্সটা এত সেন্সিটিভ, আমরা কি বলে পেন্টনিক্স চেঞ্জ করে ফ্যামোটিডিনে আসলাম, পেশেন্টের ব্লিডিং শুরু হলো, তখন তো ঘাড়ের উপর উঠে বসবে যে তুমি এটা চেঞ্জ করলা কেন। সুতরাং এইসব সিচুয়েশনে ইট হ্যাজ টু বি ভেরি কেয়ারফুলি, ইট হ্যাজ টু বি ডিলড এভরি পেশেন্ট, প্রত্যেকটা পেশেন্টই ডিফারেন্ট, ওইভাবে ম্যানেজ করতে হবে। বাট আনলেস
জি স্যার।
ইট ইজ ভেরি মাচ রিকোয়ার্ড, ইট ইজ বেটার নট টু রিস্টার্ট, বাট স্টার্ট করলে ওইটা হাতে রাখলো। আরেকটা ইম্পর্টেন্ট জিনিস বলতে আমি চাইছিলাম, ভুলে গেছি, rosuvastatin, this drug is not friendly for kidney. এটা কিন্তু আমি এই যে কয়েকজন আছে আমার সামনে সবাইকে বলতে চাচ্ছি, it is not safe. যদি যখনই ক্রিয়েটিন বেশি থাকে, AKI or CKD হোক, you have to change this drug from to other, that is to atorvastatin or ezetimibe. This this কি বলে fenofibrate is also very notorious. So these two drugs should be discarded whenever there is raised creatinine.
স্যার স্যার
জি
স্যার
স্যার।
স্যার স্যার এই বিষয়ে স্যার আমার একটা কোশ্চেন আছে স্যার, সেটা হচ্ছে স্যার রোসুভাস্টাটিন ইজ বেটার দ্যান অ্যাটরভাস্টাটিন সো ফার আই নো স্যার। এই যে
No, not for kidney, not for kidney.
স্যার তাহলে স্যার যদি স্যার সিকেডি বা একেআই পেশেন্টের ইসকেমিক হার্ট ডিজিজ থাকে তাহলে আমরা রোসুভাস্টাটিন লো ডোজ দিতে পারবো না? মানে 5
না
মিলিগ্রাম লাইক
না 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 না, ফাইভও দেওয়া ঠিক হবে না। যদি
স্যার
তার
তাহলে
ক্রিয়েটিন এটা
তাহলে
হতে
স্যার
পারে,
আমার
হ্যাঁ,
স্ট্যাটিন তো লাগে স্যার, স্ট্যাটিন তো
স্টাডি
সিকেডি
আমরা
এতে
অ্যাটরভাস্টাটিন দিব।
স্যার এটা আচ্ছা ঠিক
এটা
আছে স্যার।
যখন যখন
কিন্তু
একুট
স্যার
করোনারি সিনড্রোম হবে
কিন্তু
তখন হয়তো কার্ডিওলজিস্ট এটা মানবে না।
কিন্তু স্যার আমি একটা লিস্ট দেখেছিলাম, সেখানে বলা হচ্ছে যে স্যার রোসুভাস্টাটিন ইজ বেটার দ্যান অ্যাটরভাস্টাটিন, সিমভাস্টাটিন, ইভেন স্যার ওই যে প্রাভাস্টাটিন, এগুলোর থেকে স্যার রসু ইজ বেটার। আমি স্যার একটা লিস্ট দেখেছিলাম, সোফার আই নো স্যার, আপনি আর বেটার
হ্যাঁ
জানেন
হ্যাঁ,
স্যার।
কিন্তু রিসেন্টলি গত 1-2 বছরে যে পেপারগুলো আসছে তাতে রসুভাস্টাটিন ইজ নট ভেরি সেফ।
সেফ না
তবে
স্যার, সেফ না, বাট বেটার দেন সেফ না স্যার। সেক্ষেত্রে মানে রিস্ক বেনিফিট রেশিও চিন্তা করে স্যার
ওকে
অফকোর্স
ডাক্তার ইউসুফ, আমার মনে হয় যে এটাতে কনক্লুশন দেওয়া হয়েছে। আমরা নেক্সট কোশ্চেনে যাই।
Sir, another question is, sir, AKI patient কে অ্যান্টিহাইপারটেনসিভ হিসেবে কোনটা ইউজ করা বেটার? আমরা দেখে থাকি যে কিডনি বিভাগ থেকে স্যার প্রাজোসিনটা মোস্টলি প্রেসক্রাইব করা হয়, কিন্তু সেটা দিয়ে যদি ব্লাড প্রেশার না কমে তখন এই হাইপারটেনসিভ পেশেন্টের জন্য কোনটা সেফার হবে স্যার?
হ্যাঁ, এখানে ইনফ্যাক্ট পালসটা একটা ইম্পর্টেন্ট ইস্যু, ব্রঙ্কিয়াল অ্যাজমার হিস্ট্রি আছে কিনা সেটা ইস্যু। এই জন্য পেশেন্টের যদি ট্যাকিকার্ডিয়া থাকে, চুজ এ রেট লিমিটিং drug, either beta blocker or other calcium channel blockers, but all calcium channel blockers are safe, or all alpha blockers are safe. So this can be used. Then third, that is prazosin hydrochloric is there. Then chlorine is safe. These are all safe, but they have neurological effects. But at the outset, calcium channel blockers are safe in any situation. Okay, then alpha blocker, then go to other drugs. But diuretics also, if it is effective, can be also a good antihypertensive in these patients. Thank you.
থ্যাংক ইউ স্যার। স্যার,
স্যার
কয়েকজনের প্রশ্ন ছিল সিএলডি এবং একেআই ম্যানেজমেন্ট নিয়ে। অনেকেই অনেক সিনারিও দিয়ে কোয়েশ্চেন করেছেন স্যার, আপনি যদি অ্যাজ এ হোল
আজকে
সিএলডি
এখন থাক, অনেক রাত হয়ে গেছে আসলে।
আচ্ছা
আমরা
স্যার।
ইনশাল্লাহ আবার কথা বলবো।
স্যার একটা সাপ্লিমেন্ট কোশ্চেন যদি স্যার একটু সিম্পলি স্যার এনএসএআইডি এর ব্যাপারে স্যার আমরা বিশেষ করে একেআই এর জন্য অথবা কিছু কিছু সিকিডি পেশেন্ট কখনো কখনো এনএসএআইডি লাগে, সেক্ষেত্রে স্যার এখন যেটা বলা হয় যে নাভোমেটন ইজ মানে সেফার, বাট স্যার সামহাও আমার যতদূর মনে পড়ে স্যার আমাদের বিডি ফিজিশিয়ানসের একটা সেশনে সম্ভবত স্যার ন্যাপ্রোক্সেনের ব্যাপারে স্যার একটু প্রেফারেন্স দিচ্ছে বেটার মানে বেটার দেন নাভোমেটন। স্যার এই ব্যাপারে আপনার যদি স্যার কোনো একটু ওপিনিয়ন
এই
থাকে স্যার।
সমস্ত এনএসএডি এর ব্যাপারে আমি মাপ চাই। I will not advise any NSAID in any patients of any renal perturbation. আমি কখনো কোনো NSAID এই যে সুলিন্ডাক অর নাভোমেটন এগুলো কোনোটাই আমি ইউজ করি না। এক্ষেত্রে মোস্ট সেফ হলো গিয়ে ট্রামাডল, তারপরে হলো স্টেরয়েড, তারপরে হলো গিয়ে প্যারাসিটামল। ইন দিস সিচুয়েশন স্টেরয়েড উইল বি দি নাম্বার ওয়ান চয়েস। যদি পেশেন্টের কোনো প্রবলেম হয়, গিভ এ শর্ট কোর্স অফ স্টেরয়েড, পেশেন্ট উইল বি বেনিফিটেড। और पेशेंट যদি ভার্টিগোর প্রবলেম না থাকে, পেশেন্টের কনস্টিপেশন প্রবলেম না থাকে, গিভ ট্রামাডল or just paracetamol. No NSAID in situations of AKI.
থ্যাংক ইউ স্যার।
আমি আসলে খুবই আপ্লুত,
থ্যাংক ইউ
আমার
ভেরি মাচ স্যার।
জুনিয়র ডাক্তাররা এত মানে এত সিনসিয়ারলি, এত ধৈর্য সহকারে এই রাত 12টা পর্যন্ত এই অনুষ্ঠান মানে এইটা করছে, লেখাপড়ার জন্য যে আগ্রহ দেখে সত্যি আজকে আমার মনটা ভরে গেছে। আমি কয়েকদিন ধরে একটু
স্যার
পরিশ্রম
একটা লাইভ কোশ্চেন স্যার লাস্ট নিয়ে আমরা শেষ করে দিব স্যার। ডাক্তার জুয়েলিয়া, আপনি যেহেতু আনমিউট করে ফেলছেন, আপনাকে লাস্ট অ্যালাউ করলাম।
Sir, Assalamu alaikum. Thank you so much.
Yes,
Sir, I
thank you
have a
very much.
question that in all of these scenarios, in these 5 scenarios, I have seen that the patients who are having fluid overload, in that case, when the creatinine is high, I actually couldn't understand about the management. And the second question is that if a patient is a hypertensive patient, is having a creatinine of like slightly raised than the normal range, and there is no other symptoms in that patient. So what is the management of antihypertensive drug in that case? And in that case, how can I explain these high creatinine? Is this CKD or like hypertension induced CKD? Or I can just how to actually classify this patient, AKI or CKD?
Julia, I discussed at the outset, whenever there is a raised creatinine, we have to ascertain whether this patient is having AKI or CKD. That's the first thing we should do. That is, there are clinical ways, there is laboratory ways. So you have to be sure that whether you have to jump to manage the patients, there's patient having AKI, or you have to relax, the patient is having CKD. by taking a meticulous history, whether his patient had the previous predisposing factors, risk factors for CKD. If it is there, is likely CKD. If he has got leukonychia, is likely to be CKD. If he has got dirty, muddy color, pigmented skin, he has CKD. If he has got scratch marks in different ways, yes, he has got CKD. If he has got a features of bilateral enlarged kidney, CKD. If he has an obstructive history, is CKD. But if there is nothing like that, just raised, then follow the patients and look for the cause, whether it is a renal origin or a drug induced or something like that. So you manage accordingly to that. And if there is fluid overload, definitely diuretic is the number one choice, which will release the fluid also and will reduce the blood pressure also. But as I said in the past, one question before, antihypertensive in AKI situation, the calcium channel blocker, alpha blocker, then centrally acting drugs, then other vasodilators will be they come gradually. Thank you.
Thank you so much, sir.
Thank you so much, dear participants, and thanks so much to sir for giving us so much time out of
thank
his
you very
time.
much. And Noshin, thank you very much. You
Thank
are,
you.
in fact, so much dedication that I can't express my feelings really. Hats off to you.
Thank you, sir. And BD Physicians and Dr. Ehsan has made it possible that we have gathered here today, tonight actually, and we have already crossed 11:30. Thank you, everyone, and wish to see you again soon in BD Physicians. And thanks so much to sir. Assalamu alaikum, everyone, and a very good night.
Walaikum assalam. Allah Hafiz.
হাবিবা ফেসবুক লাইভটা ক্লোজ করে দাও স্যার ফেসবুক লাইভে অনেক